today's discussion on rheumatic fever. Today we will discuss on rheumatic fever. So thank you Axis Medical School for arranging a class on rheumatic fever. And there is cardiovascular topics. And now we'll move to the rheumatic fever in different aspects, especially for the post undergraduate students, definitely. So now something introduction about the rheumatic fever. Rheumatic fever is a delayed autoimmune reaction. That is a autoimmune reaction. Why it is delayed? Delayed because this autoimmune reaction usually occurs after at least 1 to 3 weeks of the pharyngeal infection, especially by the streptococcal infection. That is the immunological reactions that occurs, autoimmune reactions or cross reactions, whatever you call, that occurs after throat infection, that is 1 to 3 weeks after the throat infection by the streptococcal bacteria. And characterized by the inflammation of the cerebral tissues that give rise to these autoimmune reactions. What are the organ that usually involves in rheumatic fever? In rheumatic fever, these autoimmune reactions usually occurs in the joints, especially large joints. It may involve the cardiac muscles, even the endocardium, even the myocardium or pericardium or pancardium. All the layers may be involved, but usually endocardium is the involved. And it may have some sequelae or it may give rise to some complications like rheumatic valvular heart disease that usually we found as a rheumatic mitral stenosis or mitral regurgitations or aortic stenosis and aortic regurgitations. And it may also involve the nervous systems in the form of chorea. This chorea usually we call it Sydenham's chorea. That is a specific type of chorea that is also called Saint Vitus dance or Sydenham's chorea. Later we will discuss it in details. And that is and there are some also the skin involvement, and this skin involvement usually in the form of erythema marginatum and subcutaneous nodule. That is in the form of erythema margin, that is margin like the red margin like features, and there may be subcutaneous nodule, that is skin involvement. So what are the organs that usually involved or that where the autoimmune reaction usually occurs following a pharyngeal infection with the streptococcal bacterial infection? That is heart, that is joint, brain, and the subcutaneous tissue or skin. So these are the 4 organs usually involved following the throat infections, and autoimmune reactions may occur. There is no residual damage occurs in the 3 organs. That is, there is no residual involvement in the skin, or there is no residual involvement in the joint, or there is no residual involvement in the brain or skin. But there is a residual involvement that occurs in the cardiac tissues, and that may usually give rise to some complications like in rheumatic heart disease. There may be aortic valve involvement, there may be mitral valve involvement, or there may be tricuspid and pulmonary, though they are rarely involved usually. And mitral valve and aortic valve is the common involved, but mitral valve is the commonest valve involvement usually in the rheumatic fever, and they have some sequelae, that is these valves usually damaged, and that give rise to the development of the rheumatic mitral stenosis or the mitral in the form of mitral regurgitations. There is a long latent period of the 3 weeks that may 1 to 3 weeks usually occurs. So it is called delayed autoimmune reactions, and usually 1 to 5 after the 5 weeks. And group A, hemolytic streptococcus infections or acute rheumatic fever. And there may be 3 to 6% of any population may have this rheumatic fever involvement. A person may be infected with sore throat infection may occur with streptococcal infection, but all people are not susceptible to develop the rheumatic fever. That is, if a patient has got sore throat, he or she may not have the rheumatic fever. If there is a cross reaction occurs, or there is a similarity of the some tissues of the maybe in the joint, maybe in the brain or maybe in the subcutaneous tissue, or that may have some similarity with the group A beta hemolytic, especially M protein, if there is a similarity. And if this similarity leads to the development of the cross reaction, then usually the sequelae, type of sequelae, that is rheumatic fever, may occur. And this acute rheumatic fever is a systemic disease of the childhood that recurrent that follows group A beta hemolytic Staphylococcus. So usually it involves the heart, blood vessel, joint, and subcutaneous tissues and central nervous system. And etiology, we all know that that is the autoimmune reaction, and this autoimmune reaction usually occurs following a sore throat infection by the group A beta hemolytic Staphylococcus. And usually it is a diffuse inflammatory response to a cross reaction that usually involves the connective tissues, primarily the heart, blood vessel, joints, and subcutaneous tissues. So which people are more susceptible to have the acute rheumatic fever? These are the age group, usually 5 to 15 years of the age, and usually it rarely occurs less than 3 years, and usually female, that is girl baby, are more affected by the boy baby, and it is the common in the third world countries. There is a low socioeconomic countries. Low socioeconomic condition is the they are more susceptible to have the acute rheumatic fever. There may be some environmental factors like overcrowding, poor sanitation, or poverty. Yes, low socioeconomic condition is a risk factor for having the rheumatic fever. And there usually this rheumatic fever usually occurs during the fall, winter, or early morning, when there is an increased chance of having the sore throat infection. And it is the delayed immune reactions due to beta hemolytic Staphylococcus. This immune reaction usually occurs 1 to 3 weeks after the sore throat infection by the hemolytic Staphylococcus, and usually after the sore throat infection, there is an antibody production against the M protein of the staphylococcal antigen usually occurs, and this M protein, this antibody that is directed, that is produced and directed to the M protein of the staphylococcal explosion that cross-reacts with the different tissues of the connective tissue, especially connective tissues. And the tissues usually have similarity with the joint tissue or cardiac tissues or brain tissues, central nervous systems, and subcutaneous tissues that have cross reaction. And due to cross reaction, there is inflammation, and this inflammation leads to the damage of that particular tissues. And usually, strains that produces the rheumatic fever, beta hemolytic is usually M type, and it is the 16, 11, and 24 type of strain that are the strain, and usually it causes the pharyngitis. Or if usually if there is a skin infection by the group A Staphylococcus, but this skin infection, if though infected by the beta hemolytic Staphylococcus, usually doesn't cause acute rheumatic fever. Only rheumatic fever occurs following the sore throat infection. So features suggestive of group A beta hemolytic infection. Patient 15 to 15 years age. Presentation in winter and early spring. Patient usually present with a fever and headache. There is sudden onset of the sore throat. There is nausea, vomiting, and abdominal pain may have. There may be pain with there is a difficulty there with swallowing, that is dysphagia may have. There is a beefy, swollen red uvula due to the infection with the beta hemolytic Staphylococcus. There is hot palate, petechiae, that is donut lesions by the group A hemolytic Staphylococcus. This is not the rheumatic fever. This is the features of group A beta hemolytic Staphylococcus infection, that is sore throat infection. There is tender enlarged anterior cervical lymph nodes. There is a tonsillopharyngeal erythema, and patient may have exudates, and that may usually we see with the during examination of the throat actually. And this is the this is the sore throat, that is the tonsil. Both tonsils are enlarged and erythematous, and that you will see there is a uvula. This is the beef swollen uvula, short palate petechiae, that is donut lesions type of lesion. There is a redness, swelling of the throat and tonsil, and there is a tonsillopharyngeal erythema and exudate. That exudate, there is a white spots we have seen here. And this is the M protein. There is a protein antigen that usually against the M protein usually antibody are produced, and this antibody causes the cross reactions of the different tissues of the body. And this is the actually susceptible host, that is patients at the age of 5 to 15 years, patient is overcrowded, poverty condition. These are some risk factors, female baby, and when there is a susceptible host, this sort of several repeated group below beta hemolytic Streptococcus infection. There is a priming of the immune response. There is a that may lead to the development of the first episode of acute rheumatic fever due to this cross antigen. And there are usually some environmental factors, especially overcrowding is an important point to have. That is the susceptible factor to have with the rheumatic fever. There is some precipitating event like infection with the extended group A beta hemolytic Streptococcus carrying the specific virulence factors. And there may be molecular mimicry, that is antigen similarity of the between the group A beta hemolytic Streptococcus antigen, that is the host tissue, and that causes the cross reaction. And this is the genetically determined some host factors is also maybe present, and there is a first episode of acute rheumatic fever. And when there is a repeated episodes of rheumatic fever, that may lead to the development of the though there is no residual effect in the brain or joint or skin, but there is a residual involvement of the cardiac tissues, and that causes usually a cardiac involvement, and there is a inflammation of the endocardium, and there is a valvular tissues, and that causes the stenosis type of lesion, and that is a regurgitant type of lesion. And due to the recurrent acute rheumatic fever, there is a rheumatic heart disease develops. The pathophysiology, this is the causative agent like group A beta hemolytic Streptococcus antigen, and if patient is not treated properly, that may lead to development of the acute rheumatic fever, and all layers of the heart or the mitral valve may be inflamed. So endocardium, myocardium, and pericardium, all the three layers of the heart may be involved, and then it may be also the vegetation forms may also occur. There is a valvular regurgitation or STD type of lesion that may lead to the development of the cardiac involvement. Eventually, patient may have features of heart failure also. This is the tonsil. There is a both sides around. There is the uvula. There is a group A beta hemolytic infections, and usually following the group A beta hemolytic infection, usually at least 1 week or to 5 weeks, there is a cross reaction, a cross antigen may occur, and that may lead to the development of the acute rheumatic fever. There may be arthritis or arthalgia, that is joint involvement. There may be cardiac involvement, and there may be carditis. There may be endocarditis or myocarditis or pericarditis, or there may be pancreatitis also. And there may be skin involvement that may be derivative of the erythema marginatum, as well as patient may have subcutaneous nodule also. And when there is a nervous tissue involvement, especially the basal ganglia, that may lead to the special type of chorea that is called Sydenham's chorea or St. Peter's dance also. And following a streptococcal infection, and the involvement of the different tissues, the duration of the involvement of the different tissues may vary. Just following the rheumatic fever, the joint may be involvement, and carditis may take some time. Even erythema marginatum, following erythema marginatum may follow the acute rheumatic fever. But chorea usually occurs usually 1 to 2 months after the sore throat infection, and subcutaneous also takes some time to develop the subcutaneous nodule. But polyarthritis, cardiac erythema marginatum may occur usually 1 to 5 weeks following the sore throat infections. And these are the key morphologic features of the acute rheumatic heart disease. There may be fibrinous pericarditis, myocardial Ashof's nodule, Ashof's body, Ashof's nodule may be found in the cardiac muscle tissues, the myocardium. There may be vegetations also in the endocardium that may lead to development of the regurgitation type of lesions. And this is the actually due to the cross reactivity. And this is the rheumatic granuloma. It is a rheumatic granuloma by Ashof's nodule. Usually there is a plasma cell lymphocytes may have, collagen fibers may be, but then may fibrinoid collagen necrosis. There is a Ashov cell also present. There may be Anitkov cells, Anitkov cells, that is histocytes also may be present within this rheumatic nodule also. And now we'll discuss in details about the carditis, syndrome chorea, the arthritis, and the subcutaneous nodule and marginatum. This is actually the features that is the tissue that involves and that produces some features when this organ is usually involved. Now carditis incidence varies completely with 60%. That is, all patients having acute rheumatic fever may not have carditis. Only 50 to 60% patient may have carditis. And the clinical diagnosis of carditis in index attacks of rheumatic fever is based on presence of significant marker. How we can diagnose this patient may have carditis? If patient develops significant mitral regurgitation, that's a new onset mitral regurgitation, that is mitral regurgitation, aortic regurgitation. If present, then we can suspect this patient may have rheumatic fever. Patient may have pericardial rub, and this is the features that indicate this patient may have pericarditis. That eventually patient may have a pericardial rub, and there may be unexplained cardiomegaly with congestive cardiac failure. This is due to the different and more than one valve involvement. A patient may have aortic regurgitation type of lesion or mitral regurgitation type of lesions. This patient may have congestive cardiac failure, and there is a cardiomegaly may be found in the X-ray or when you do echocardiography. And it is common in young patients, and 80% of the patients develop within the first weeks of the rheumatic fever. That is, usually it occurs early when patient have rheumatic fever. Now we will discuss on the endocarditis or valvulitis. This is the innermost layer of the heart, that is endocardium, and then maybe endocarditis. And usually we all know that this valve is a special form of endocardium actually, when there is a folding of the endocardium that produces actually the valve. So endocarditis and valvulitis is the similar thing actually. Always, almost always associated with the murmur of the valvulitis. When there is a murmur, then we can suspect that this patient usually have endocarditis or valvulitis. A universal finding in rheumatic carditis, whereas the presence of pericarditis or myocarditis is variable. So usually patient have valvulitis or endocarditis at first. Then if the reaction is severe, cross-reaction is severe, then myocarditis may have. So if the infection is cross-reaction is more, then along with endocarditis and myocarditis, patient may also have the pericarditis. So endocardium, myocardium, and pericardium involvement may indicate if three layers are involved, and so we can see that there is actually severe cross-reaction. So endocarditis is the first tissue that is usually involved, and pericardium is the last tissue that is usually involved. So at first endocardium is involved, then myocardium, and then pericardium is involved usually. 90 to 95% mitral valve involvement usually occurs. We have also already discussed that the mitral valve is the common valve that is usually involved in case of the rheumatic fever, and 70 to 70% of the isolated mitral valve is usually involved. 20 to 25% of the aortic valve is usually involved. So second to the mitral valve is the aortic valve that can be involved with the rheumatic fever, and that may develop, may lead to the development of the aortic regurgitation and also the aortic stenosis also. And 5 to 80% of patient may have isolated aortic valve involvement, that is without involving the mitral valve. 5 to 8% of the patient may have isolated aortic valve involvement. And patient may have, due to the involvement of the endocarditis or rheumatic valve involvement, patient may have pansystolic murmur in the apex radiating the axilla. That indicates that patient may have mitral regurgitations actually. And AR in the absence of MR is uncommon. So usually AR in the absence of it is important. Usually we found mitral regurgitation, and then a patient may have aortic regurgitation. When we usually found a patient having rheumatic fever and aortic regurgitation is found, then eventually all of the patients with rheumatic fever should have mitral regurgitation also. So first attack of rheumatic fever, there is maybe apical holosystolic murmur of the mitral regurgitation, with or without mid-dystolic murmur or Cardiac murmur. That is, patient may have a mitral regurgitation without any mitral stenosis. If there is acute rheumatic fever, usually when there is acute rheumatic fever, patient may not have mitral stenosis. Mitral stenosis is a sequelae of the chronic rheumatic heart, repeated attacks of the acute rheumatic fever actually. But in the first attack of the acute rheumatic fever, patient usually, as there is a valvulitis or endocarditis, usually patient has features of mitral regurgitation actually, or aortic regurgitation. And patient with previous rheumatic heart disease, a definite change in the character of any of these murmurs or the presence of any significant murmur, that is important. That is the pattern of the murmur is changed, or there is the appearance of the new murmur that indicates the patient develop rheumatic fever, acute rheumatic fever, or there is a recurrent rheumatic fever also. The severe mitral regurgitation is associated with the worst prognosis. The fatal heart failure may develop due to the severe mitral regurgitation. Incidence of the chronic rheumatic heart disease is 90%. Linear relation between the severity of MR during the first episode of rheumatic fever or subsequent rheumatic heart disease. So, pathogens of the severe mitral regurgitation. Why mitral regurgitation occurs in a patient with rheumatic fever? There is a valvulitis, there is a mitral annular dilatation that may lead to the development of the mitral regurgitation. The leaflet prolapse without the caudal elongation, and there may be caudal rupture also due to rheumatic fever involvement. So this is the actually causes that may lead to the development of the severe mitral regurgitation. There may be Caricum's murmur. This is a mid-diastolic murmur without pre-systolic accentuation. It's called the Caricum's murmur. This is the actually associated with the severe mitral regurgitation actually. Due to increased flow through the diseased mitral valve, and this usually occurs due to the increased blood flow through the diseased mitral valve. This is Caricum's murmur. This is a mid-diastolic murmur actually, but there is no perisystolic accentuation, and as there is no stenotic lesion actually. This occurs usually due to mitral regurgitation, and this is usually due to the increased flow across the mitral valve. And at the episode of the acute rheumatic fever, valve changes can be minor or still able to regress. There may be mitral valve involvement, and the mitral valve severity of the mitral valve may be minor. And even after, if there is no recurrent the rheumatic fever, these features of involvement of the mitral valve may be regress to the normal over the time actually. But after the recurrent episodes of acute rheumatic fever, the valve is becoming thickened, and there will be stenotic lesion, development of the stenotic lesion, and the mitral valve orifice may be reduced, and there is a permanent damage of the valves also. And this is the here we see that this is the mitral valve, this is the anterior mitral leaflet, this is the posterior mitral leaflet. Anterior mitral leaflet is thickened, posterior mitral leaflet is also thickened, and there is more calcified also this, and the AML and PML are also calcified. And due to the mitral stenosis, the left atrium is enlarged, as there is a obstruction of the flow of the blood from the left atrium to the left ventricle. And here we also see that aortic valve. This is the aortic valve. Aortic valve is also thickened. Aortic valve is also calcified also. So there is the aortic valve involvement. So in this patient, aortic valve and mitral valve both are involvement due to rheumatic heart disease or chronic rheumatic heart disease process. And here with the morbid anatomy, this is the there is a rheumatic heart disease involvement. There is a thickened mitral valve, and this is a fused thickened chorda tendineae. And this is the myocarditis, and myocarditis is always associated with valvulitis. And new onset cardiomegaly and recent change in the cardiac size, it may indicate the most specific sign, and that is that indicates the patient may have myocarditis. No consistent elevation of the cardiac biomarkers. There may be biomarker may be elevated, or then maybe there is a normal cardiac biomarker. No evidence of systolic dysfunction. Congenital hypervalve does not occur without significant valvular lesions. Nuclear status failed to demonstrate significant myocardial staining. Biopsy in acute rheumatic fever failed to show cellular necrosis. Inflammation was subendocardial, subendocardial, and perivascular. Surgical valve replacement during the rheumatic fever, acute rheumatic heart disease, the reverted features of the heart failure. And there may be Ashok's nodule that do not contain myocardial cells usually. And now pericarditis. 16 to 15% of the rheumatic heart disease patient may have the pericarditis, and there is quite typical pain, chest pain, and there may be friction rub, the pericardial rub when you are scalded. Always associated with rheumatic valvulitis, may be associated with normal ECG, may be associated with diffusion, but rarely cause a constriction and tamponade. This type of actually pericardial, if pericarditis may produce some pericardial effusion, but then usually it doesn't happen any constriction and tamponade. This is the rare possibility if a patient having pericarditis due to rheumatic fever. It presents denotes severe carditis also. Now the carditis And then we move to the polyarthritis. Arthritis, that is joint involvement. And you all know that polyarthritis means there is more than 2 or 3 joint involvement. That is polyarthritis. And the 60 to 75% of the rheumatic fever patient may have polyarthritis. And this is the most earliest manifestation patient may have this most earliest manifestation is the polyarthritis. Typically involves larger joints. Actually, larger joints are more involved, like knee joint, ankle joint, wrist joint, and elbow joints. The involved joints become red, become hot, swollen, and tender. And this is usually migratory in nature. Why this migratory? Because migratory means that when there is involvement of the knee joint, so when the knee joint inflammation is resolved, that is knee joint condition is improved, then another joint is usually involved. There is fleeting arthritis. That is, it migrates from one joint to another joint actually, and that is not deforming. This is the most important, because we all know that in rheumatic arthritis, the joint is usually deformed, but in rheumatic fever arthritis usually this is not deforming, except the JACCOUD'S arthritis. We'll discuss it later on. A dramatic response to a small dose of salicylates. That is, this is the most important thing. This pain, this inflammation is usually very much sensitive to the salicylates. That is aspirin ingestion. If we give aspirin to a patient suffering from acute rheumatic fever with joint pain, usually the joint pain subsided when the patient ingests or taking salicylates, that is aspirin. And the very much this rheumatic fever arthritis is very much sensitive and responsive also to the aspirin therapy. And the synovial fluid acute rheumatic fever usually has 10,000 to 1 lakh WBC per cubic millimeter of fluid, exuded with normal glucose, neutrophil predominance here. There is the disease is actually self-limiting and normalizes by 2 to 4. After 2 to 4 weeks, usually this arthritis is automatically resolves without any anti-inflammatory drugs actually. Polyarthritis and symptoms never occur simultaneously. That is, when the patient has symptoms, this patient should not have polyarthritis. If a patient has polyarthritis, this patient should not have any symptoms. Inverse relationship between the severity of the arthritis and cardiac involvement. That is, if a patient has got cardiac involvement, usually his arthritis is very much less. And if the patient has got severe polyarthritis, and then the patient usually cardiac involvement is less. That is, the relationship is usually the patient is inversely proportional. Severity is inversely proportional. And here we see that this subcutaneous nodule, actually this is very rare. Only 2 to 20% of the rheumatic fever patient may have this type of subcutaneous nodule, and it is freely mobile, and usually it is painless and freely mobile. Here the size is usually varies from 0.5 to 2 centimeter in diameter, and it occurs in cross over bony prominences or extensor tendons. That is usually extensor surface or bony prominences. It usually occurs over the bony prominences actually. And common locations are the elbow, wrist joint, knee joint, ankle joint, Achilles tendon. Now, where usually we found this subcutaneous nodule. And this is the erythema marginatum. What we are seeing here in the patient having the rheumatic fever. This is the erythema marginatum. And this is the usually occurs only 3 to 15% of the patient having rheumatic fever. This is the erythemata serpiginous. That is serpiginous means that means this is the snake-like lesion. That is সাপের মতো আঁকা বাঁকা lesion. Is erythemata, that is lal redness, serpiginous macular lesion with pale centers that are not pruritic. This is not pruritic. That is mad. It is not itchy actually. There is no itching there is no allergy actually. And with pale centers, actually the macule type of lesion with the pale center, that is margin is red, but the central point is actually pale. There is a multiple lesions primarily on the trach, where actually we found this erythema marginatum. Usually we found it over the trunk, and there is a proximal extremities, rarely on the distal extremities and never on the face. Usually we found it in the trach and proximal extremities. This is upper limb, but lower limb is very much rare. And this erythema marginatum never actually found in the over the faces. It occurs rarely in course of the rheumatic fever. It may occur early in the course of the rheumatic fever. A patient with in the early course of the rheumatic fever, you may get that's erythema marginatum you can get. And erythema marginatum is non-painful, non-pruritic, blanches on pressure. If we just apply the pressure, that is this erythema usually goes, that is blanches on pressure. Accentuated by the warming the skin. If we warm the skin, then the erythema is usually prominent and the lesion is usually prominent. Non-influenced by the anti-inflammatory therapy. If you give to control the inflammation, there is usually that not response to the anti-inflammatory drugs. It is associated with carditis. That if a patient has a carditis, this patient may have erythema marginatum also. There's nodules and prangitum can occur simultaneously. If a patient have subcutaneous nodule, as well as the patient may have erythema marginatum, and that can occur simultaneously. It is also seen in sepsis, dehydration, glomerulonephritis, and this erythema marginatum. As we found this erythema marginatum in the patient having rheumatic fever, but we can get it as well as the patient having the septic reactions, that is sepsis, and if there is a drug reactions, or if a patient has glomerulonephritis. In all cases, we can get erythema marginatum. And now we'll discuss on the chorea and synonyms chorea. This is synonyms chorea. This is also called St. Vitus dance. And it is usually we see 5 to 30% of the acute rheumatic fever patient, and it is generally more prevalent in females, and it's rare than less than 20 years actually. So patient having rheumatic fever usually we see after the age of 20 years. This has synonyms chorea usually occurs. Isolated, frequently subtle and neurological behavior disorder. This usually chorea may occur as isolated. So if a patient has chorea, this patient may not have any arthritis, may not have any carditis, even the patient may not have any features in the skin. So it may be isolated, and there may be neurological behavior disorder patient may have. The patient may have emotional liability in coordination, poor school performance, uncontrollable movements, and facial grimacing. We will see that later on. Exerted by the stress and disappears with sleep. When the patient gets sleep, usually it disappears. And this usually when the patient gets stress, this chorea is usually exacerbated. And there is seen occasionally unilateral. It may occur unilateral. The synonyms chorea may have the long latent period. That is, after a long period of the acute rheumatic fever, patient may develop chorea. Clinical maneuvers to elicit features of chorea include demonstration of the milkmaid's grip, irregular contraction of the muscles of the hands while squeezing the examiner's fingers. There may be spooning or pronation of the hands when the patient's arms are extended. And there is the Ormian darting movements of the tongue upon protrusion. When there is tongue protrusion, there may be Ormian darting movements. Examination of the handwriting to evaluate the fine motor movements. And patient actually do not cause permanent neurological sequelae. When the patient usually completely patient may be resolved. There is completely recovery can be achieved in a patient with synonyms chorea. And this is the type of dance, St. Vitus dance. Here we see that this is the defined body movement, different types of body movements can occur in a patient with synonyms chorea. This is the dance, St. Vitus dance or synonyms chorea, which we found in a patient with synonyms chorea. And rheumatic chorea, this is the marker of future carditis. If a patient has rheumatic chorea, this patient may have carditis at the later on. 23% of pure rheumatic chorea develops mitral stenosis in 20 years of follow-up, and 27% in 30 years follow-up. That is very much important. If a patient have synonyms chorea, so there is an increased chance of having the mitral valve involvement, especially the mitral stenosis may develop later on. So chorea is rarely associated with polyarthritis. Inflammatory markers, ASO titers may be normal. In case when there is a synonyms chorea in a patient, these inflammatory markers like ASO titer or CRP may be negative, and ASO titer may be normal in case of synonyms chorea. So we have discussed the major criteria. Now there are some minor manifestation of minor criteria like arthalgia. Patient may have fever. Patient may have epistaxis seen in the 4% cases. That is the nasal bleeding. And patient may have abdominal pain also. That is the 5% of the cases. Patient may have abdominal pain also. And there may be some extra cardiac manifestation. That's a mimetic feature of rheumatic chorea. Those patients who develop extra cardiac manifestations in the first attack, there is a least chance of develop carditis during the recurrence. Whereas if the initial attack is carditis, there is a high chance of recurrent carditis. So first attack, if it is in a first attack of rheumatic fever, if the patient doesn't have any carditis involvement, that is cardiac involvement, later on, there's a subsequent recurrent rheumatic fever, there is no usually cardiac involvement occurs. But in the first attack, if the patient has carditis, then in the subsequent rheumatic fever, there is a recurrent, there is an increased chance of having the recurrent carditis, and patient may have the sequelae of the recurrent carditis, and patient may develop valvular heart disease, that is chronic rheumatic valvular heart disease. So this is another type, JACCOUD'S arthritis. We have discussed that usually patient's arthritis is completely resolving, that is completely the patient get well soon completely. But in this type of, that is rheumatic fever, it is the one type of rheumatic fever where we can get also there is a deformity. We all know that there is usually no deformity, no residual involvement in that joint. But in case of JACCOUD'S arthritis, patient may have this type of deformity that usually we see in a patient with rheumatoid arthritis actually. This is JACCOUD'S arthritis, the chronic post-rheumatic fever arthritis, seen in patients with severe rheumatic heart disease and not associated with evidence of rheumatic fever. Recovery delayed associated with the stiffness of the metacardiophalangeal joints. Characteristic deformity due to periarticular, fascial, and tendon fibrosis. Joint disease inactive but normal ESR, negative RF factor here. Here is the RF factor is negative and ESR is also ESR. And joint disease inactive actually. Deformity as characterized by flexion at the metacarpophalangeal. So deformity is here. There is a flexion at the metacarpophalangeal joint with unlearned deviation of the fourth and fifth fingers. And there is a hyper extension of the proximal interphalangeal joint actually. Initially, the deformity is correctable, not associated with bone destruction. So this is the correctable type of lesion. And this is another type is the PANDAS, that is pediatric autoimmune neuropsychiatric disease associated with stomachaal infection. This is also a sequelae of the stomachaal infection usually in children. This autoimmune response that cross-react with the brain tissue in response to the gas infection actually. Their patient may have obsessive compulsive disorder as well as that it may be patient may have tic disorder. And usually in these cases, patient do not need any secondary prophylaxis. This is the Jones criteria. Jones criteria, that is, this is the most important thing actually to diagnose the patient if the patient having rheumatic fever or not. This is the Jones criteria update 1990, the modified Jones criteria. There is a major manifestation actually we have discussed already. There is patient may have carditis, polyarthritis, chorea, subcutaneous nodule, erythema. These are the 5 points that are the major criteria. And there may be some minor manifestation of minor criteria like fever, arthralgia, prolonged PR interval in the ECG. There may be lab findings like elevated acute phase reactant protein, CRP, the increased ESR or CRP. And there should be some supporting evidences of preceding stomachaal infection, positive sore throat culture for group A hemolytic staphylococcus or rapid antigen test, elevated or rising stomachaal antibody titer. So this is the actual features. If we get this type of features, we can diagnose a patient with rheumatic fever. Actually, we diagnose how can we diagnose a patient if there is at least 2 major criteria, and if there is evidence of recent local infection, then we can diagnose a patient have rheumatic fever. If there is at least 1 major criteria, at least 2 minor criteria, and if there is evidence of stomachaal infection, recent stomachaal infection, then we diagnose the patient has rheumatic fever. So this is the way how can we confirm a patient may have acute rheumatic fever. So this is the different classification given by the World Health Organization and other organizations. There is no gold standard diagnostic technique to diagnose the acute rheumatic fever. Those actually no definite laboratory test. We can do throat culture sensitive for to have the recent evidence of stomachaal infection. Initially consider gold standard for diagnosis of stomachaal infection actually. There may be some limitations, difficult to differentiate a carrier from active infections. 1/3 of rheumatic has no history of preceding pharyngeal infection. Delay in getting culture report actually. A rapid antigen test we can do, and that is specific for 95% and sensitive for the 90%. And a stochastic antibody test we can do for supporting the evidence of respiratory infection like ASO titer, anti-DNSB, anti-hyaluronidase, and estradiol. And this is the ASO titer. ASO titer has got limited importance to diagnose the acute rheumatic fever. That's also the supportive treatment. Supportive, that is a minor criteria actually. And usually it appears 7 to 10 days after the infection with the peak detection and 2 to 3 weeks after the onset of the rheumatic fever actually. ASO titer of more than 2 odd units in adults and 320 odd units in children more than 5 years is elevated. And serum samples obtained 2 to 4 years interval actually done. And there should be more than 2 dilation increment needed to diagnosis actually. This is the B cell marker, the CRP, ESR, ECG, the acute rheumatic fever. Patient may have only sinus tachycardia, or even ECG may be normal in case of acute rheumatic fever. Patient may have sinus brachycardia, patient may have PR prolongation, and it is usually seen in 2 to 30% of the cases. This sinus bradycardia usually occurs due to the vagal overactivity or myocardial inflammation. There's no correlation with carditis and future development of the rheumatic heart disease. And high grade of AV block can occur, and even patient may have complete heart block also. And we can get also the features of the pericarditis in the ECG, and patient may also have the QT prolongation in a patient with acute rheumatic fever in the ECG findings. And in echocardiography, we can diagnose confirmly if there is a valve involvement, mainly rheumatic valve and mitral valve involvement. In rheumatic mitral valvulitis, we may get the caudal elongation, annular dilatation, intermittent leaflet prolapse, or there may posterolateral jet of the mitral ligation jet can also we can get. There may be also some features of acute rheumatic carditis having no clinical murmurs. This is the echocardiography features of rheumatic carditis actually. And restricted movement of the hair, we see that there is a AML, that is the acute intermittent leaflet of the, which is the mitral valve. This is AML, this is a PML, posterior mitral leaflet. There may be restricted movement. So there may be hockey-shaped appearance, or the actually domain usually we call it. There is a visuous echo score. There is a visual-Lokhi echo scoring. Usually we do 2 diagnosis for criteria for the rheumatic fever involvement. That's a chronic rheumatic heart disease. Rheumatic heart disease involvement actually. If there is a mitral valve and aortic valve thickness more than 4 millimeter, mitral valve regurgitation or aortic valve regurgitation is occur, mitral valve prolapse, rheumatic nodules, pericarditis, caudal tear, reduced mobility of the valves, increased echogenicity of the submitral structures. Yeah, there is a total scoring is 8 into 2, that is 16. If echo score more than 6, that is diagnostic of rheumatic carditis. We can confirm the patient may have rheumatic carditis actually. We can also do endocardial biopsy for confirmation of the rheumatic fever. There is a Ashworth nodule you can get by myocardial biopsy. This is the myocardial biopsy. And by treatment, usually there is a primary prevention and there may be secondary prevention. And both type of prevention may be needed. And there may be treatment of the acute rheumatic fever. And usually there's primary prevention, that the eradication of stomachache infection usually occurs. And if there is the involvement of the acute rheumatic fever, usually we treat with aspirin and steroids, and that patient may need some supportive management and management of the complications if present. And due to secondary prevention, and that is prevention of the recurrent attacks, usually we do penicillin prophylaxis to the patients actually. This is the penicillin prophylaxis actually. So I think we can stop here today. So this is all about the acute rheumatic fever, the management of the acute rheumatic fever actually. So thank you very much for your great attention. Thank you all.